Hi, I'm John Burton, Chair for the Department of Emergency Medicine at Carilion Clinic in Roanoke, Virginia. Many hospitals and emergency departments, when they're contemplating starting a bridge program from their emergency department for opioid use disorder services, they think that this is a very challenging thing. And while there are a number of key components to consider, the challenges really are not that difficult or the obstacles that high. First, a historic issue is that people often think that's just not what we do in emergency departments and hospitals treating opioid use disorder and opioid addiction. We need to break through that mindset. The numbers are staggering, and it's clear that there's a need in our communities to make a difference for these patients with opioid use disorder. Second, we often think this seems kind of complicated. The steps to get started are difficult. There's certifications to be done, there's new medications to prescribe, and things to consider. In reality, none of these are very high obstacles. There are a few things that have to be done, but none of it's complicated, and certainly not as complicated as what we do in emergency medicine and in our hospitals every single day. Finally, people will often say, we feel like we're going to open up the floodgates if we start one of these programs. By opening one of these programs, there's the concern that there will be more and more people that will come in with opioid addiction. There are already people in our community, as we know, lots of people in our community and in our emergency departments who are coming in who have suffered from opioid use disorder. Individuals with opioid addictions are common throughout our services, and facing the reality of that is something that creating a program like this really opens our eyes towards. By starting a program, we won't open the floodgates. We'll just recognize the problem and actually start managing and caring for the problem instead of looking the other way. Talking about each of these challenges, in contemplating starting an opioid use disorder bridge program, let's first talk about the concept of that's not what we do. In reality, it is what we do. Every single day in emergency medicine, we see individuals who have opioid addiction in our practice, opening our eyes to the truth of that addiction and then turning that truth into how we can help these individuals in their recovery and in their journey is a critical opportunity for the field of emergency medicine and hospital-based providers. Individuals who are having opioid addiction problems will frequently have wait times to get into therapy of weeks or months, and creating a 24/7 program in an emergency department bridge automatically allows us to open up access for those individuals when they're ready to start. This is a time-dependent therapy for these individuals. When they are ready to start recovery, whether it's because of a recent overdose or motivation from the challenges of their addiction, then we should be ready to respond and start their program. An emergency department bridge program allows us to do that 24/7. And finally, when one looks at the mortality across the United States over the last decade of opioid addiction, the numbers are simply staggering. Unfortunately, during the pandemic, the matters became even worse and the death rates have soared. Let's talk about this perception that creating an emergency department bridge program for opioid addiction is a very complicated process. It's really not. There are a couple of key partners that you have to have. First, you have to have an office-based outpatient therapy or OBOT program, and you need to have a very close association with that program, particularly around policies and procedures in dealing with patients. Let's take it through the emergency department visit is probably the easiest way to do it. First, with the history and physical examination. The clinical opioid withdrawal score is a great way to organize oneself around the history and physical examination of individuals with opioid addiction. Whether this is during the time of an overdose or if the patient is simply presenting to the emergency department in some range of no withdrawal up to more likely mild to moderate or even severe withdrawal. The CAL score will organize you around thinking about that patient and should be documented in the medical record. Also, during their visit, if you can bring in social work or a peer counselor into strategy, that is always a great thing to do. We found in our work that involvement of peer counselors is a critical step in improving the likelihood of success in the program, particularly of getting the patient from the emergency department into the outpatient therapy setting. During the emergency department visit, the majority of patients will require a dose of suboxone. This is not challenging. Prescribing suboxone is very straightforward, and really this should be dictated based on the amount of withdrawal that the patients had, their previous experiences with suboxone, and the unique elements of the clinical situation. We have found that treating patients in the emergency department with a dose of suboxone and getting that therapy started, as well as then giving them the prescription for follow-up, does then translate to higher rates of success in getting patients to show at the outpatient clinic in the subsequent days. You'll want to have very specific discharge handouts instructing the patient what you've agreed to do as their care provider and what you expect of them as the patient, and your expectations in treating them and their follow-up as an outpatient provider. Finally, let's break down the training itself. In order to prescribe suboxone, physicians and physician assistants and nurse practitioners, providers, will need an X waiver. Much of the X waiver training has been simplified in the last 2 years during the pandemic, and this is a very simple online set of steps that can be done and registering the X waiver with the DEA. Another concern that people have when they're starting an opioid addiction program with an emergency department bridge strategy is that it will open the floodgates for patients coming to the hospital and the emergency department for these services. The data on opioid addiction in our country is very clear. No area of the country has been spared, and there are large numbers of individuals who are suffering from opioid addiction in our communities. Therefore, these patients are already here. And really the better strategy is what can we do for them while they're here. Starting an emergency department bridge program gets one organized around recognizing these individuals and starting to do therapy for them and even tracking them in your healthcare system. In our emergency department program here at Carilion Clinic, our bridge program tracked our patients 1 year before they came to the emergency department and started entry into the bridge program, and their 1 year after being entered into the bridge program. And we did not see the floodgates open and visits rise amongst these patients. Quite the opposite. The visits for these patients went down 40%. It made us understand that these individuals were already using our services in our emergency departments at a very high rate, multiple visits throughout each year. And as we've gotten them into successful treatment programs, they consistently reduce their utilization of emergency department services. Next, seeing these individuals on a shift is not a difficult patient encounter. There's not a lot of tremendous challenge, particularly relative to the other difficult things that we do in emergency medicine for our patients. We typically in our program here at Carilion Clinic will see 2 to 3 patients per shift. So even with a mature program that we have had in place for a number of years, we certainly have not seen the floodgates open on a per shift patient visit. And finally, many of these patients come in very desperate, even suicidal, concern for their own health and their own future, and starting them into an emergency department bridge program ultimately translates into hope for these individuals. In the end, I can summarize by telling you that we aren't opening the floodgates. If anything, we're making a difference in the patients who are already there. The Carilion Clinic Bridge program has had some very strong results, and we've been very pleased with the outcomes of our program. First, let's talk about patients crossing the bridge. By that, what I mean is a patient comes into the emergency department, is enrolled in the program, and referred to the other side of the bridge, which is the outpatient therapy program. In the first year of our program, we had an 82% success rate of patients crossing the bridge into the outpatient realm. Second, let's talk about retention in therapy. We set as our goal to look at 30-day retention in the outpatient program, and in the first year of our program, we had a 90% success rate of individuals who did cross the bridge remaining in therapy out to 30 days. In our data analysis, we found a number of factors that were associated with successful crossing of the bridge for an outpatient treatment encounter. First, suboxone treatment in the emergency department treating patients in the emergency department increase their likelihood of crossing successfully the bridge into outpatient therapy. Second, a CALS score greater than 11. Patients who are in moderate to severe withdrawal, who are also then treated with suboxone, are more likely to show at the outpatient follow-up appointment than those who are not in withdrawal in the emergency department. And then finally, peer counselor involvement in the emergency department. While it's not always a component that can be done in all emergency departments across the United States, there is an opportunity in a number of locations to involve peer counselors. Peer counselors give someone during the visit and following the emergency department visit leading up to the outpatient therapy an opportunity to connect with a patient as a peer, as someone who's gone through the process before and can be connected with as the patient makes their journey into the outpatient setting and ultimately throughout their therapy.